Patient-specific implants in orbital reconstruction. So thank you once again for being here this morning. I'm Tarjani Dave. I work at LV Prasad Eye Institute in Hyderabad. I have no financial disclosures to make pertinent to this talk, and I do have consent for the display of photographs of my patients. I'll take you through what patient-specific implants are, the advantages that they have, a little bit on virtual planning of these implants, and what are the widely used materials at this point of time. So that was a reality check on height after Hosoxas presented. All right, so some indications of patient-specific implants like congenital defects or tumors, trauma and infections, where we could use them. Most of these are in secondary reconstructions, and then conclude the talk. The orbit, like we know, has a very complex three-dimensional structure, and there are a lot of functional consequences of orbital and soft tissue trauma. There also are aesthetic implications from orbital trauma. And what has changed in the past decade is the availability of better quality imaging, especially the DICOM data that is available from CT scans for treatment planning. You also have to your access navigation or image guided surgery and real-time intraoperative imaging that can help you give better outcomes to your patients. With all of these technologic advancements, there's also been an advancement in the field of implants that are available for orbital reconstruction, and patient-specific implants are such bespoke implants that are individual to a patient and a defect. You can see over here is a couple of implants crafted for an orbit which is much enlarged compared to the other side, and there is a defect in the greater wing of the sphenoid. This is a patient with a plexiform neurofibroma that also has a meningoencephalocele into the orbit and is producing a pulsatile proptosis. While soft tissue debulking with the several techniques that are available does help, pulsatile proptosis is actually an issue that needs to be kind of managed by creating an implant that will bridge that gaping hole in the greater wing of the sphenoid. And that can only be done by implants which are individualized to the defect. And this is what essentially a patient-specific implant can do. The advantages here are that these implants offer you a higher accuracy of correction because you've spent a lot of time before the surgery planning what the shape and size of the implant should be, what its contour should be, and hence as you slip it into the defect you have much better site adaptation and you don't need a lot of intraoperative tweaking. This also reduces your surgery time and certainly gives you better post-operative results in select cases where your run-of-the-mill implants will not give you the correction that you're looking for. Generally, these implants are available in a variety of thicknesses, but the commonly used ones are around 1 millimeter thickness, especially the titanium implants are 1 to 2 millimeters in thickness. This is a relatively thick implant. You can tweak around with the thickness if you're using different kinds of material. What is the virtual planning that I was talking about? So essentially what you do in this step is you want to normalize the orbit. So if it's just one orbit that's involved, you already have the contralateral orbit for reference, and that's used as a template and is projected onto the abnormal orbit, and then you bridge the areas wherever there is a defect. For instance, here an implant has been crafted to sit in on the lateral wall of the orbit in that same patient with plexiform neurofibroma that I mentioned. Along with this, you can see that the right side orbit also has an increase in the vertical dimension of the orbital aperture. And that is also corrected by symmetrizing the orbital aperture to the contralateral side. So all of this can be used by or done by readily available online softwares, and there are several companies that can help you do this kind of planning. For instance, here's a case of trauma that you can see has been corrected, but there's absolutely no bone here. There's just an implant holding a small bit of the zygoma to the frontal bone and absolutely no floor or maxilla, and that's just been bridged with the help of a mini plate here. And this patient obviously had soft tissue consequences as well. So what was required for him is to have the facial skeleton normalized and the orbital volume also normalized, and that's where you can create such bespoke implants that are unique to a defect and a patient. The good part about these steps of virtual planning is that you can actually see what the orbital volume on the contralateral side is, and then can try and symmetrize it on the affected side. For that, if you have to raise the posterior end of the plate that goes on the floor of the orbit, you could go ahead and do that. Or if there's any other change that you want to make, you're free to do that, and even try it on a model of the patient's skull that is printed before you actually try it on the patient during surgery. The materials that are available are largely titanium, polyethyl ether ketone PEEK, porous polyethylene. Also, these days, bioresorbable implants like polycaprolacton are available for you to craft as a patient-specific implant. Titanium is a rigid implant and gives excellent structural stability, but if that patient-specific implant needs further contouring intraoperatively, it's very difficult with titanium. That's one disadvantage, and this exactly becomes the advantage of a porous polyethylene or a PEEK or an osteomesh or resorbable implant when crafted as a patient-specific implant. So with this little background, the indications essentially at this point of time remain very irregular orbital defects for which you do not have a run-of-the-mill implant available, and defects where you have multiple walls of the orbit that are fractured, which you think will not fit back into position. Possibly if you have loss of bone for any reason, and in situations where you're performing revision surgery for residual defects, these are the cases where you would want to go ahead and craft a patient-specific implant. I'll show you some patient examples here. This is a lady who has a maxillary sinus ossifying fibroma that also involved the orbit, and she had a complete excision, but then it leaves her with a defect where she's lost the entire maxilla, she's lost her upper jaw, she's also lost the floor of the orbit in order to completely remove the tumor. And what we were able to do for her in a primary sitting is to craft an implant that gives her back the orbital floor, the maxilla, and also gives her the potential to have osteointegration to get new permanent teeth in her upper jaw. And all of this would not be possible by using standard implants. This is how her skull model and the implant looked, and that's her radiology post-operative. And this is her post-operative. You can see that little faint scar along the nose. She certainly had an excellent outcome with the reconstruction. Here's the lady who I've been showing you earlier with the plexiform neurofibroma. She had debulking of the soft tissue, but she had significant hypoglobus and pulsatile proptosis, and we were able to reduce that hypoglobus and pulsatile proptosis with the help of these implants. She still needs some soft tissue work, but nonetheless, if you look at her bony skeleton, we've been able to give her back the orbital rim that had receded, as well as the lateral wall, which pushed the brain back and sort of reduced the proptosis post-operatively. Here's another gentleman who had congenital hemifacial hypoplasia, where again the bony skeleton has been corrected with the help of these patient-specific implants to improve the projection of the face, and over that he has a prosthetic eye. Compared to the preoperative picture, you can see that the hollowing has settled down much better. Here's another gentleman who had a bear attack, and on the right side he has secondary nasolacrimal duct obstruction, for which we performed a DCR. But what was of interest is during the primary intervention that he had, the eyelids were completely closed in a blepharopathy, and he was living like this for the past 20 years. He did tell us that he had good vision before the blepharopathy, and he wanted to explore the possibility of opening up his eyelids and seeing if he was able to see again. This is how his facial skeleton looked. There was significant loss of bone all around the orbit, and we crafted an implant for him, because if you have an eyeball which is open but no support for it, obviously there'll be exposure keratopathy. And we opened up the blepharophy, did a mucous membrane graft for the posterior lamina to keep the eyelid separate from the ocular surface, and also reconstructed the orbit with the help of this patient specific implant. He did see, he had about 2200 vision, with that he did quite well with his blepharophy. This is yet another patient who had mucormycosis, and I treated him during the active epidemic of mucormycosis that we had in India during COVID. We were able to spare his eye, his vision. He had 20/20 vision, but then from the mucormycosis, he developed osteomyelitis, for which he required debridement of bone, which was also done. And this is how his bony skeleton looked, and he was dependent on this tarsorrhaphy because there was now no support for the eyeball inferiorly, since we had debrided this bone. We were not able to release the tarsorrhaphy, and he was very keen to have his orbital aperture normalized. And 5 years after his debridement, we planned a patient-specific implant, and this is how his implant sits. Over a period of time, we were able to wean him off his tarsorrhaphy, but then I saw exposure of the titanium implant. So this again is a situation where I've burnt my hands, and I've learned that in situations where your overlying skin cover is compromised, if your subcutaneous tissue is not adequate, you probably want to be very, very careful in using patient-specific implants. Here is another patient with mucormycosis who actually over a period of time did very well, a very similar presentation to the previous one, where we placed the implant and it sits there beautifully. He's had almost a 5 or 6 year follow-up now. This is how his implant was fabricated, and this is him about 5 or 6 years later, having good support to the lower eyelid and no exposure symptoms at all. This, unlike the previous patient, is a situation where we had very good soft tissue cover, and therefore there was nothing to worry about in terms of exposure. In conclusion, I've spoken to you about what patient-specific implants are, the indications for planning, and certain case situations where you should use it, with a little bit on situations where you should be wary of using such implants. Thank you so much.